Hi guys, welcome back. So now we're gonna do paper 8. This is the third paper for today. So the first question is for Precordium Examination, which includes inspection, palpation, and auscultation, which I've literally just done for paper 9. So I will skip this bit, but I think on paper 9, I forgot to mention about the palpation of the PMI. So I said that we need to palpate for heaves, lifts, and thrills, but I didn't mention the palpation of the PMI. So to palpate for the PMI, so the PMI is usually located at the apex of the heart. So we just find the apex of the heart, which is usually at the fifth intercostal space, mid-clavicular left-hand side. We try locate the point of maximal impulse using our fingertips, and then just try locate the pinpoint exactly the location with just one finger. And you need to assess for things like the location. So as I said, typically it's on the apex of the heart, but in some instances it can be transposed to the other side of the heart. For instance, in patients with dextrocardia or situs inversus, or even with pregnant patients, because the diaphragm is pushed up by the uterus, the PMI might be a bit higher than normal. And then you need to assess for the diameter of the PMI. So the PMI usually is between 1 and 2.5 centimeters in diameter when the patient is lying supine. But when the patient turns to his or her left lateral decubitus position, then it may feel bigger as the chest wall gets closer, as the apex of the heart goes closer to the chest wall in that position. And you also need to assess the amplitude. So the amplitude of the PMI is usually small, and it feels like a gentle tap. And if it feels diffused, then this may suggest left ventricular dilatation. And if the impulses feel sustained and more than just a gentle tap, then this may indicate left ventricular hypertrophy. All right. So moving on to the respiratory system, we need to assess transmitted voice sounds. So transmitted voice sounds, we assess for these when we hear any adventitious breath sounds. If we hear any added sounds like wheeze, crackles, we assess for transmitted voice sounds. Okay, for 5 points, we need to assess transmitted voice sounds, including bronchophony, egophony, and whispered pectoriloquy. So starting with egophony. So egophony, we ask the patient to say E, as in beat, and we basically auscultate for the, does it say? Okay, here it doesn't mention if it's posterior or anterior chest. Let's just talk about posterior chest. So for posterior chest, we need to auscultate those 7 areas for bronchophony. So as we ask the patient to say E, as they feel the stethoscope touch their chest. And we do that on all of those 7 locations. And the normal result would be that we would hear the sound E through our stethoscope. But the abnormal sound would be the E sound would change to a more nasal A sound. And if this happens, then this indicates consolidation of the lung. And then for bronchophony, so bronchophony, we ask the patient to say 99 when they feel the stethoscope touch their chest. So normal result would be the sounds would be muffled and indistinct. And abnormal would be that the sounds are easy to hear, clear, and distinct, And again, this indicates consolidation. And then for whispered pectoriloquy, similar principle, we ask the patient to whisper 99, so 99, 99, as they feel the stethoscope touch their back. So we would expect the sounds to be very, very, very faint, if any at all, and to be muffled and very indistinct. And the abnormal result would be the sounds would be loud, distinct, and clear, again indicating consolidation. Right, moving on to the great vessels assessment for 5 points as well. We need to assess the carotids, the abdominal aorta, renal arteries, iliac arteries, femoral, popliteal, posterior tibial, dorsalis pedis. We need to palpate and auscultate. All right, okay. So carotids, firstly. So carotids, we start with inspection for any visible pulsations, any swelling, any redness in the area. And then we move on to palpation. So we palpate the lower third like area of the neck in the medial border of the sternocleidomastoid, where we can feel the carotids. So we can palpate the carotids using our index and middle finger. The things that we look for are like the rate, the rhythm, the contour of the pulse. So for the contour, we assess like the speed of the upstroke, the duration of the summit, and the speed of the downstroke. So usually the upstroke is brisk, and the summit is smooth and rounded, and the downstroke is less abrupt than the upstroke. And we do that on the other side as well for comparison. We never palpate both carotids at the same time because this will lead to syncope. And we auscultate the carotids for any bruits, okay? Which just means turbulent blood flow. And when we auscultate the carotids for bruits, we ask the patient to stop breathing just for a few seconds, just so we can clearly hear the bruits without the breath sounds in the background. And then abdominal aorta. So abdominal aorta is located in the epigastric region. So again, we inspect for visible pulsations, any obvious injuries to that area, any swelling, and then what we do is we palpate. So for palpation, we estimate the size of the abdominal aorta between our two fingers, and the diameter, the size should be less than 3 centimeters. This is particularly important to do if we have elderly patients who have been chronic smokers who are still chronic smokers, because they're at a very high risk of abdominal aortic aneurysm. And then after palpation, we need to auscultate again for any bruits. And then moving on to renal arteries and iliac arteries. So these are non-palpable arteries, so we can auscultate them, however. So renal arteries, so remember that the abdominal aorta is in the epigastric region. So renal arteries are like in the right and left upper quadrants. So we auscultate the bilateral renal arteries and the bilateral iliac arteries, which are located in the right and left iliac region, okay, of the abdomen. And again, for any bruits. And then femoral arteries. So femoral arteries are kind of in the inguinal ligament, like midway from the anterior sphenoid spine in the pubic symphysis. So we just trilocate the pulse. We press deeply in the inguinal ligament to feel for the femoral pulse. If the patient is obese, for example, then we could use 2 hands, so one on top of the other, to apply like a deeper pressure to help us feel for the femoral pulse. So if the femoral pulse is absent, then this may point towards peripheral arterial disease or arterial insufficiency. If the pulse is diffused or widened, then it may point towards like the dilatation of a femoral aneurysm. And then moving on to the popliteal pulse now. So the popliteal pulse is behind the knee. So okay, this pulse might be really tricky to find because it's a lot deeper than the other pulses, and it feels a lot more diffused. So what we need to do, we could do this when the patient is lying supine. We like slightly flex the knee, but ask the patient to keep their leg relaxed, and we just like cup the knee, so our fingers our at the back of the knee and in the midline, and we press deeply into the popliteal fossa to try feel for the popliteal pulse. If we can't feel it in this way, we can ask the patient to go on their prone position and lift their lower leg, and we support their lower leg on our shoulder. And then what we do is we press deeply on the popliteal fossa using our two thumbs and try feel for the popliteal pulse. And after the popliteal pulse, we move further down. So we have the Dorsalis Pedis and the posterior tibial. So Dorsalis Pedis, we need to palpate for it. It's on the dorsum of the foot, kind of like in the midline, above the ankle. So this may be congenitally absent, or the artery may branch out further up. So we just need to readjust our position when we're palpating for this, but it's definitely there. I can feel mine. And then the posterior tibial is located behind the medial malleolus. So we just curve our fingers and feel for the posterior tibial pulse behind the medial malleolus. I think that's it for the vessels. And then moving on to the musculoskeletal system, we have back inspection and back palpation. So back inspection. So for back inspection, we just look at the patient's posture as they sit when we're talking to them, or as they walk in the examination room. And we look for the erect position of their head, the neck, and the spine. And from the side, we look at the curvature of the cervical spine, the thoracic spine, and the lumbar spine. And an increase in the curvature of the thoracic spine, so increase in kyphosis, is not necessarily pathological. So this is like a normal process that occurs in aging. So, in elderly people, they might have a more exaggerated kyphotic spine. And then from the back, we look at the patient's spinal column for any asymmetries, any deformities in the spine in the back region, and for the alignment of their shoulders and the iliac spine. So if their shoulder heights are uneven, then this points towards scoliosis. Also, if their iliac crest heights are uneven, which is known as a pelvic tilt, again, this can point towards scoliosis, or just the fact that they may have unequal leg lengths. So yeah, and then we need to test for the range of motion of the back for 2 points. So it includes flexion, extension, rotation, and lateral bending. So flexion, we basically just ask the patient, so we have the patient standing up, we ask them to bend forwards as far as possible, try touch their toes, and that's flexion. And extension, we basically support the patient by supporting their back and ask them to bend backwards as far as they can. For rotation, we just ask them to rotate side to side. And for lateral bending, we just ask them to bend side to side. So that's the range of motion of the spine.